Thanks, Rob, and apologies that we are later than planned. I hope that hasn't caused too much inconvenience. So we are looking at the Q4 report from the Guardian for Safe Working. Do you want to say anything else, or should I just hand over to Rob?
Chair, I did want to say something. I mean, it is an independent report from Rob as the Guardian of Safe Working, but I just wanted to update the board about the action related to the trainees in obstetrics, if I may. So really, I've sought information from the clinical director for obstetrics, and also from the deputy director of medical education, who happens to be an obstetrician. First thing to say is that the survey of trainees that was reported in the maternity incentive scheme paper was actually, because of the delays in the GMC survey and the way they are published, the trainees who were surveyed in that were actually working in the obstetric department in 2018. So that is the first thing to say. It's about 3 years ago. The most important thing is that they've looked at any exception reports that have been filed during 2019 to 2021, and there have been 2, according to them. And they've also assured us that they've looked at all the rotas which are fully staffed and which were fully staffed and compliant, except in the emergency time during COVID, where they had to make changes. Now, this is against the backdrop that during COVID, training as a whole has suffered, and that's recognized nationally. And Health Education England has recommended that certain specialties extend their period of training. And these include craft specialties like obstetrics and gynecology, surgery, anesthesia. So along with our Dean, Michael Bannon, when he does put forward the specifics as to which trainees require extension of training, we will be working together to achieve that. But as related to the action from that report 2 months ago, there is not a concern at the moment in obstetrics and gynecology. Thank you. Rob, over to you.
Thank you. So I'd just like to say thank you to everyone for inviting me. It's really appreciated. I was last here a year ago, and just attending that meeting, there have been knock-on benefits throughout the year. So thank you very much, and I would like to join again next year if I may. Also, thank you just for confirming that you will have read the report. I just want to draw your attention to one error in the report, in that the table Appendix 2 is actually incorrect and refers to an incorrect quarter, but the actual data described within paragraph 3.4 is correct. But I actually don't want, in terms of my report to you now, I don't want to dwell too much on specific data points. So essentially, as the Guardian of Safe Working Hours, I'm in a fortunate position in that I'm neutral within the Trust, and I'm here to ensure that any issues related to compliance with safe working hours are addressed by either the Trust or by junior doctors where appropriate. And I've been asked to talk about 3 changes since we've last met and 3 priorities for the year ahead. And actually, I was going to combine those. And there's an overriding theme here of what I think of as being joined up networks and communication. And obviously, you know, buying property, we all talk about location, location, location. And actually, I think the take-home message from my report is communication, communication, communication. So I'm going to divide that into 3 sub-themes. So the first sub-theme relates to people in the organisation. And in response to the pandemic, I actually saw some really good practice when representatives from the Chief Medical Officer's office came together with Chief People's Office and junior doctors from the Junior Doctors Forum. And they worked really well together. And the benefit of that wasn't seen just in terms of how we clinically responded to the pandemic, but it was also seen in terms of how some trainees can actually provide excellence in leadership and provide an insight to senior members of the organisation in terms of what's happening on the ground floor. And I think we really need to embrace that. But my observation is actually the way in which the organisation worked together with trainees worked really, really well. And I was really impressed by that. Conversely, again, it's understandable, but it was the pandemic. I think there was some overreaction in all sorts of aspects of our working lives at the beginning of the pandemic. But I did see examples of individuals working within departments, rewriting rotas for junior doctors with good intention to make sure that departments were adequately staffed, but they didn't communicate their changes with central medical staffing. And that meant that really, in terms of oversight, we didn't know what was going on. Trainees couldn't exception report properly. Their new working hours weren't registered with payroll, for example. So there were some basics that didn't happen. So good intentions to begin with, but by not following that process and not linking up with others in that stakeholder group, that did lead to some issues. But I think in terms of people, I really do think that there's an opportunity with doctors in training to actually use them at a more senior level in terms of the leadership they can provide. They're getting on for 900 junior doctors. So you can imagine, can't you, at any one time, there's probably going to be one or two who are going to be sort of significant leaders in the future. And I think we need to take advantage of that. And I've mentioned in the report two by name who really, I say, they excelled in that position. Second sub-theme is communication, and I'm really just talking about the tools of communication here. So over the last year, a personal observation is that trust-wide communications have improved significantly. And there are a number of different tools for communication, and what is being communicated, I think, is of a good standard. And additionally, the rapid adoption of Microsoft Teams as a tool to enable meetings to take place during the pandemic, again, is really appreciated, and that's worked really well. And it's enabled meetings to happen that actually were quite challenging beforehand. So there are some good examples of trust-wide communication. However, despite that, we do get feedback from trainees with a sort of common theme of, I wasn't told about that, and the message not reaching them. And I think there is a real challenge here relating to targeted communications for specific stakeholder groups. So if I want to communicate with all junior doctors, so that would include all doctors who are employed in a training post and all doctors who are locally employed. And I know from experience that I approach various people and ask them to send a communication out on my behalf. And obviously that issue, having to do that is a little bit irritating. I'd rather just sit down and be able to send it myself. And I also know that eventually I get feedback from some trainees saying, we never received that message, despite me being assured that actually the person who I approached knew who all the various doctors were. And then at a more, I suppose, nuanced level, if I, for example, wanted to contact all doctors at the Horton because there's something specific to the Horton, I've got no way of accessing those, apart from just trying to work out who all the different stakeholders are and contacting them individually, and it's time consuming. And again, it's very rare that you reach the whole of that stakeholder group. So targeted communications to specific stakeholder groups, I think, is a challenge. And then the third sub-theme is on information. So this is what we recognised last year, that obviously these reports that you read, the data should just speak for itself, shouldn't really require any interpretation, and it should paint a full picture of working life for doctors in training here at OUH. But we recognise that nationally, there are sources of data relating to their working lives that are mutually dependent on each other so that we can understand the data and provide context. But those different systems do not communicate with each other. So they stand alone and they require a lot of human intervention, which is then subject to interpretation. So we recognised that a year ago. So I'd like to pass on my thanks to both Meghana and Terry Roberts for recognising that and putting a mechanism in place so that we've now got a task and finish group that has met a few times over the years. And that task and finish group, now chaired by the Director for the Medical Workforce, has recognised the challenges and the risks that we face. And again, I just want to reiterate, these are national risks. And they've also recognised the opportunities. So, in terms of deploying medical staff, safe staffing levels, appraisal, job planning, revalidation, lots of data associated with all those things. They're all interlinked. And actually, if they were linked via some sort of intelligent network, obviously there'd be benefits all around, and it would allow the organisation or provide evidence to the organisation to demonstrate their performance against national standards. So I think when I pull all that together, what I'm really describing is that we have lots of individuals and tools for communication and for collecting data, but what they don't do is they don't sit together as a joined up communicating network. Lots of good examples of sort of people working excellently in their various silos, but not particularly well joined up. And I think that's why I just want to sort of push on this theme rather than start delving into specific data points, because I'm not sure I trust all the specific data without that overriding intelligent network.
Thanks, Rob. You won't be surprised to know that that's not unique to the area that you're working on, that challenge. Meghna, you've raised your hand.
Thank you, Chair. I just wanted to thank Rob for his work during this time alongside the junior doctors, and particularly the Junior Doctor Forum. What I do want to say is it is a particular challenge contacting all junior doctors, as in trainees and locally employed doctors. There seem to be separate databases for foundation school, for the STEM trainees, and for higher specialist trainees. And the biggest challenge, as it were, is that many of them do not look at OUH emails. They have their own email addresses and their own groups that they seem to have, and they give to their local supervisors, but obviously we cannot use their out of OUH emails. So Terry's team and my team are working through this. And this is also something we've raised on the joint local negotiating committee, where there are junior doctor reps, because we do have to bring it together. And, they change every 4 months. So there has to be some central mechanism that we can have that enables somebody at a stroke of a button to go, in this 4-month period, these are the junior doctors in this organization. It's not insurmountable, but it clearly is a slightly complex task.
Thank you, Meghna. Could I ask, and this is probably for you, Meghna, as opposed to Rob, but the point that Rob's raised about, first of all, the recognition of a few individuals who've done exceptionally well in this group and how we do that, but more importantly, looking forward, how we could systemize the recognition and embedding these opportunities. And you and I visited the Junior Doctor Forum, must be almost 2 years ago now, mustn't it? Because it was quite early when I came. It seems like, I think Rob's point is well made. We won't necessarily know which ones are going to be there, but we can be pretty confident that in a place like OUH, we will have some very able people who we'd want to identify and foster leadership ambitions for early on.
Chair.
How would you take that forward?
So, Chair, there are two things. One is there were actually Junior Doctor Awards last year. They were meant to be hosted in the lecture theatre, and then COVID came along, so I had to send certificates to all of them rather than meet them and speak with them. So so we will no doubt repeat that this year. Second thing is there are, as you will know, lots of national fellowship schemes in leadership and management run through the faculty in support, or well, alongside Steve Powis and various national leaders. So there's plenty of opportunity to support applications to that, and we've been sending that around this time to promote. And indeed, I'm aware that many, or at least 3 local trainees who've gone on to be National Medical Director Fellows. So that is an opportunity. And then a number of them also engage with the Management in Medicine program through Green Templeton College, where they come and shadow a number of us. And indeed, one of them is here today. So a number of things happening, Chair.
Thanks very much, Meghna. Terry.
Also, as part of the Growing Stronger Together programme, we're looking at recognition. You would note from many of our presentations beforehand that recognition is a key part of that, and commemoration as well. And we've got a group that's actually engaging with all of our staff groups to look at how best we can recognise and support all of our staff. So they'll be looking at junior doctors as well as consultants, as well as all of our staff groups as well. So we're expecting recommendations to come back from that group, which will feed through to exec, TME, and subsequently the board as well.
Thanks, that's very reassuring and encouraging. I wonder, Megan, whether we might think for the future about whether there is a point in the year, whether it's the annual report that Rob brings, where we also bring alongside it just an acknowledgement of things that have been done with the junior doctors, so that we got to get it formally recognised on our agenda, and we reduce the risk that the receipt of Guardian Safe working reports sort of gets felt like a bureaucratic exercise, as opposed to a contribution to delivering a high quality experience for our junior doctors and their contribution to the high quality of care that we give. So it'd be quite good, wouldn't it, to put those alongside each other at one point in the business cycle?
Of course. Just a couple of things, Chair. One is that many of them are recipients of the Reporting Excellence Awards through the year. And also, secondly, the narrative that you've just suggested is included in the quality account. But what we will do is bring it together with Rob's report and also Claire Pulford's report, which is the annual report from the DME.
Thank you. I mean, it just feels like there's a really good story here that, a little bit like Rob said about the challenges of communicating with everybody, we can often lose the big picture by the way we fragment the reporting cycle. Thank you. I don't see any other questions for Rob. I think that our main issue was the maternity issue, which was explained to us last time we picked it up, and just reassured that that loop is closed. And I'm particularly pleased, Rob, to have heard about the contributions that the junior doctors have made. So we know that your job is challenging, but it's worth it, because these are not just the doctors of the future, they're the doctors of here and now, and they're making a very valuable contribution. Jason, is it on this item, or are you prejudging?
Point I should have put my hand up slightly earlier. I just wonder, Rob, you made a remark, and I've seen it sort of, anecdotally from various sources from around junior doctors, about the irritation or worse caused by trying to pay our junior doctors the right amount of money each month, recognising that the complexities of how the deaneries move them around and such like makes it quite hard to do. I just wondered if you would comment on how widespread a source of stress that was, because it's a notorious problem nationally, but I wonder if Terry and I should take away some thinking about, is there anything we can do better on that? I know it's a hard nut to crack, but I just don't know how high it ranks in your impression of our junior doctors' sort of working conditions.
So I've observed over the last few years that when junior doctors join the organisation, significant improvements have happened, because I think that was picked out. A senior trainee did a survey probably about sort of 4 or 5 years ago that led to a trainee engagement event with the previous medical director that was very successful. And so improvements have happened. Obviously, the medical staffing team centrally are a small team. They've got very strict rules and regulations to work around with respect to data protection and various employment checks that they have to do that makes their job very challenging. So I've seen improvements there. I think, as we've seen with COVID often highlights some issues that might be bubbling under. So I think when the rotas were changed, the issue arose because the rota coordinators weren't communicating with central medical staffing. So I don't think that's a common issue, but I think that's fairly easy to fix. If there's one group of junior doctors that this commonly affects, it's those trainees who are working less than full time. And that, I think, that whole group, there are all sorts of challenges with working less than full time. But again, the positive story is that within the last year, the Trust has appointed a champion for flexible working, and we've got 2 junior doctors on the Junior Doctors Forum who are also less than full-time trainees. So it is a recognised issue. It's a national issue. Things have improved over the last few years. The group that I'd be most concerned about, the less than full-time trainees, I think there are steps in place for that to improve. But obviously, I think as the board, you'd probably want to hear back on that in the future.
Thank you.
Thanks so much. And I think we would, but not now, Rob. So I think we can release you to other things. So thanks very much
That's
for
great.
again and for that introduction background and some really good news about contributions junior doctors are making and recognition of your challenges and hopefully people working to try and support you in overcoming them. Thanks very much.
That's great. Thank you very much.
We now move on to item 9, which is the Freedom to Speak Up update. And I perhaps should introduce it by just noting our thanks to Jane Hervey, who's stepped down as the Freedom to Speak Up Guardian. And Eileen will be briefing us on the next steps on that. Eileen.
Thank you, Chair. So given the importance of this service to the Trust and the benefit we've seen of having a strong service during the COVID pandemic in particular, my thanks to Bruno, Jonathan and Claire for working with me to consider next steps and where we take this forward. Having met with the FTSU team individually, they were all very keen that we take this opportunity to pause, reflect and consider what it is that we would like from the service, how we strengthen and enhance the service going forward. And the paper in front of you is really to update you as to the position where we're at and to seek your endorsement of commencing an 8-week project with some dedicated project support from my team to work with the organisation and to co-design with the staff, listening to people who've either used the service, who would like to use the service, who have felt they couldn't use the service, as well as looking with the management and the leadership about what they need to be able to effectively respond to people's concerns. So it was really to seek the board's endorsement of commencing the project, noting the interim arrangements that we're putting in place, and I meet with the team again in the coming week, next week, to ensure that we are managing the gap while we get the interim guardian in place. We've advertised it and it has gone live, and we welcome applications from individuals. And happy to take any questions, Chair.
Thank you very much, Eileen. I think Claire and I have both had not exactly exit interviews, but we've had catch-ups at the end of Jane Hervey's time so that we can make sure that we're cited on things that might be transitioning through, and I think we're supportive of the fact that some interesting ideas have come out in the discussions with staff, and therefore we should take stock of those and take the benefit of that experience and set of insights rather than rushing into a solution. Katie.
Thanks. Yes, Eileen. So the report is great, and I very much applaud the idea of just taking a pause, just to see, what can we do better? I mean, it's a great service, but what can we do better? Just a quick question though. One thing I found really good has been the listening events, and so I'd like to firstly say that and say how good they've been, but I'll also ask you, do you anticipate there being any listening events in that 8-week period?
Thanks, Katie. That proved a very effective mechanism for us during the pandemic to really ensure we were hearing staff concerns in real time. Absolutely. And we have more listening events that we're planning for the rest of this year between Terry's team and myself. And it's a shared objective for us in our new objectives as execs going forward for the team. We think that it's about getting those very targeted and making sure that we're able to reach people as well, because it's a combination of the in-person and the virtual, and making them available as well at times to reach staff who are not working core hours. So weekends, out of hours, evenings and nights, they can sometimes be the staff that are least involved or have the least opportunities. So we're going to absolutely endorse that approach during the project. And I think the key message that kind of came out of the discussions with the team, with Claire, Jonathan and Bruno, and with the execs when we looked at it, was about co-design and making sure that it's a process that helps us address concerns, not just listens and then doesn't do anything about it.
Lovely, thank you.
Thanks, Eileen. So are there currently dates for listening events sort of in people's diaries that NEDs could be alerted to, and if they're available, join?
There's a draft schedule being developed at this moment, Chair, and it largely depended on whether or not we were going to endorse the 8-week project, because then there will be 2 different types of listening events running, one about designing the service and one just about listening to what's on people's minds otherwise at the moment.
So looking at the chat and looking around, I think you have the support of the board for the 8-week project. I think you also have interest in the non-execs of joining some of those listening events, because we found it an extremely valuable way of getting feedback and understanding what staff experiences are. So I think if you can take that as a green light, both for the project and also to kick off that schedule and to circulate to colleagues the opportunities to join events, that would be gratefully received, I think.
Thank you, Jonathan. We're briefing the organisation in the staff briefing in the morning, so I will be able to echo the board support. And my thanks again to colleagues for their support during the pandemic on implementing this programme.
Thank you very much. That then was the Freedom to Speak Up update. We move to amendments to scheme of delegation. I'm going to try and be pretty swift here, Jason, because this comes, as I understand it, with the recommendation that we should move it forward from the audit committee and has been looked at by TME. So unless there are some googlies in here that we might not have spotted, I'm inclined to invite the board to approve it. But I'll just check with you whether that's an acceptable process.
I feel, Chair, like I've had a very strong steer, which I'm not inclined to reject. So we can go straight to questions.
Okay, so this has been through, as I've said, the audit committee process and TME, and we would usually accept those recommendations unless there's something that doesn't make sense to people. Has anybody got anything they wanted to check and get clarification on? No, thank you for taking the steer, Jason. So I think that enables us to agree the amendments to the scheme of delegation, noting the assurance we take from those due processes to get to the board. We then move on to receive and note items, and ordinarily we would spend quite a lot of time at the first board meeting to formally receive the NHS staff survey results, but as colleagues know, we have spent a considerable amount of time looking at them because we wanted to get on as soon as they emerged. We've also briefed and discussed them with the Council of Governors, and staff are aware. So I think this is probably primarily a short item, but Terry, let me just check whether there's anything that you've progressed since we last discussed it that you particularly want to draw to our attention.
I agree, Jonathan. It is a short item. We've had lots of discussion at this with NED's governors at TME and other areas. The only updates are that actually we've moved forward. You'll probably notice that there's a difference in our growing stronger together. We've now got a tagline on there that says rest, reflect, and recover, and that's after we've consulted with staff as well to get that in. We've done some further work with divisions as well to develop their action plans. We've also starting a process of the pulse surveys, which will give us an opportunity to make more immediate actions rather than waiting for a year for the staff survey to come out and then for us to have one action plan. And the only other thing is that we've attached into this how we've benchmarked against Shelford groups. And you see that we have improved if you looked at that report over time, and we're doing well. And we've also added in how we perform against Bob Truss as well. So I'll stop there and open up for questions if there are any further questions.
Thanks, Terry. I've got Claire and then Ash. Claire.
Thank you, Jonathan. It was really an observation, actually. When we heard about the sort of patient experience item earlier, I think it became really clear how important the involvement of staff has been in getting that right, but also how motivating people found that. And I know we've sort of had feedback in the past that we've been quite a centrally controlled organisation. And I think when we think about engagement and how we measure engagement and how we consider promoting it, we need to really think about that involvement.
Yeah, I completely agree. I think that the approach that we've taken is that actually in the divisions, it'll be broken down to the different directorates and to different teams so that actually they can help co-create solutions. And it's not only the teams and the directorates that we're looking at, we're also looking at how we engage our staff networks to co-create. So we've taken this to the EDI steering group. We've highlighted with our different staff networks. You know, how do you help us solve the problems that we have? So I completely agree with you, and it's an approach that we are taking forward.
Brilliant, Terry. And just to say, thanks for the benchmarking. I found that very helpful.
Thank you, Claire. Ash.
Sorry, mine's more general, because obviously this is the first time I've joined you, so I've not been party to any of those conversations you've had before. So probably, Terry, might be quite nice to have an offline conversation with you about some of the things that have come from that, or Jonathan, just to be brought up to speed with what you've done since the survey came out.
Definitely, I'd be happy to do that, Ash. I'll make sure that we time in the diary.
So Ash, I guess at headline level, when I arrived, so that's a little over 2 years ago, our staff survey results were moving in the wrong direction and were concerning in terms of staff's confidence in the organisation, supporting them, doing the good job, and engagement. And we have progressively improved both in terms of the response rate, so we're more confident in the information that comes back, and in the results there. So you'll see that pretty much all the indicators are moving in the right direction, and we'd obviously like some of them to move further and faster, but the consistency of that picture, I think, is reassuring that the steps that Terry and colleagues have put in place are doing the right things. So I think we feel that this shows us that we need to continue the direction of travel as opposed to change, and we'll give you a more detailed briefing on the things that have gone into that. And we had quite a long discussion amongst board and a long discussion with the governors around this, but when the information became available, it was embargoed, so we were not able to in the public session. So that's why it's a rather shorter item for today than it would normally be, because we already had to go around it. So we'll brief you on that offline, Ash.
That's fine, thank you.
Thank you. Then I think then we should move on from the survey results to the learning from deaths report for Q3, and that's you, Meghana.
Thank you, Chair. I'll be brief. A couple of things here. One is, the first thing to say is our HSMR for the calendar year 2020 remains below expected at 89, and SHIMI, which is a summary hospital level mortality indicator for December 19 to November 20, also remains as expected at 0.9. So good. The second thing I want to highlight is we have 4 types of reviews now into all mortalities, all deaths. That's stage 1 review, stage 2 reviews. They're both undertaken by peers, so it's not by the consultant under whose care that patient was. We also have structured judgment reviews, as you know, and we also now have the medical examiners review. We have 7 medical examiners who've now started their work with much greater ability to be on site after COVID. And Chris Kearns is the lead examiner, and I know I've met with Chris, and they're also ramping up the number of reviews they undertake. And I think the thing I really want to highlight from here is that Chris is in receipt of feedback from the families, the bereaved, that the medical examiners meet and discuss the cases with. And the first thing and the overwhelming feedback is that this is such a fantastic addition to the already existing good process surrounding death certification and speaking to families. And of course, there's more detail about the same aspect of care in the next paper. So I will stop there, and I'm happy to take questions, Chair.
Thank you, Meghana. Are there questions for Meghana? I've got one, Meghana, so while anybody else decides, and it relates both to this paper and also to the next one, as you've indicated. I'm very pleased to see in this paper that the reviews of patients with learning disabilities has identified that we haven't given them a poorer service than others, and and it just raises a general question for me, really, about whether we're doing as much as perhaps we should do to understand whether there are differential experiences from our patients. And obviously there was quite a lot of national publicity around the inappropriate blanket uses of do not attempt CPR for some groups of older people or people with learning disabilities. And I just wondered whether we have enough granularity in our analysis of the experience of with learning disabilities from particular ethnic groups, whether we need to think about any postcode analysis. Do we look after people from some parts of Oxford better than others, or it may be that the numbers are too small to make that sensible, but it's a question I think I would like to ask you, so I am.
Thank you, Chair. So I do know that there's a lot of granular detail about patients with learning difficulties discussed at the mortality review group, and it goes through the LEADER program. We don't analyze deaths by ethnicity. That's something we could do, particularly after COVID, when it came up that the risks for patients of Black and ethnic minority groups were much higher. So we can certainly look to doing that. I don't know if that would be an easy process because it's never been done. Certainly, I haven't done it in the last 9 years, but absolutely willing to consider it, Chair, and see what that shows and where it takes us. With regard to DNA CPR, and I'm sorry, I'm merging it with the next paper now, but with regard to DNA CPR, really good audit done by our teams in between March and June 2020, when the first interim report that came out from the CQC, and they looked at 178 DNA CPR instructions or requests on EPR. They're all electronically documented on a standard template, which is a good thing. And all of them had specific reasons articulated electronically, along with discussions with patients or families. And they were all compassionate conversations. Now, there's always room for improvement, and I think we're going for that. More importantly, there was no evidence of inappropriate decision-making, Chair, and that was very, very clear. The report from the CQC about respect and involving patients and families in these decisions is very clear that nationally we need to roll out respect. And we were well ahead of the curve in January 2020 with BWE, who is a consultant in palliative care, who is the National Clinical Director for palliative care and has been for the last, I think, 6 years, with Bea and her team to work alongside Oxfordshire CCG to roll out respect, not just in secondary care, but also in primary care. I think that is very, very required. You can't just stand alone, because it's about advanced care planning. So we do need to get organized again to roll respect forward. And there are a few recommendations, such as improved oversight and assurance. And there will be a group that's put together that will work alongside the end-of-life care group chaired by Mary Miller and Bea to bring all these recommendations into place. But the most important thing to say is that our baseline is good, very good. We can only progress even better, make progress even more than where we are.
Thanks, Megan. Megan doesn't need to apologise for blurring these two items because I did it, but I do think they come together. So I'm very happy for people to raise questions that read. So on the monitoring, Megan, I mean, I'm very aware that then it may not be worth doing the analysis if the analysis won't show us anything that's robust, and it might be quite a long time frame in order to do that. And so I'm not saying rush to do it, but if you could consider what would be useful analysis, I think that would be good. Sam.
Thank you, Chair. I just wanted to share that we're currently scoping the refresh of the patient experience delivery plan. There's a new national learning disabilities and autism strategy that's just been launched. We've got LD specialist nurses within the patient experience team. And of course, the other half of Tommy Snipe's role is around patient experience. So I just wanted to note that we'll look forward to bringing proposals around equality amongst our patients in terms of experience forward, probably for next board.
Tony, thanks very much, Sam. Tony?
Thanks, Jonathan. Two questions, one of which has really, I think, mostly been answered, and that was in relation to end-of-life care. Because the learning from deaths, I think one thing which it showed us many things, but one thing really was that for many, well, let's say not many, but a substantial number of patients, end-of-life care wasn't optimal, and plans were not put in place, etc. So it's very reassuring to hear from Meghana that that's all really being very actively addressed, because I think that's a hugely important role. And that's do not resuscitate aside. It's simply planning the patient's end-of-life care. The second question was just to ask that when the medical examiners do review cases and identify those where there may be concern about care provided by OUH, whether all of those or most of those have already been picked up as a serious incident.
So of all the cases they've reviewed in the last year, there have been 2 that they've asked for a structured judgment review. They don't think it's been a serious incident. So I think there is definite collaboration between the medical examiner group and the mortality review group, because they attend mortality review group, and they have the ability to raise issues that they might have found when they've reviewed cases at that group, and also directly to myself. And as I say, there have been 2 cases that they've asked for a structured judgment review on, but not wanted to make it a series. And if they do, they obviously can do that.
Yes, I mean, it's actually quite reassuring that when you do review a case and you find there are areas of concern, and you go back and you find that they have already been raised as serious incidents, because that supports the robust reporting
Absolutely.
system that we have.
Thank you. I think that takes us to Paula.
Or when I put my hand up, Jonathan, I was going to make the point you made about ongoing monitoring of this area, actually, which I think is really important. So I will simply echo what Tony said about how reassuring I found it to read this report and to find that we were in this place, such a tough area, but it was a really good report. But the ongoing monitoring is the piece that was preoccupying me as I was reading it, but I'll leave that in Meghana's hands.
Thank you. Sam, your hand's still showing, but I think you've already made the point that you needed. Yeah, thank you. In which case, I think, Meghana, we've done items 12 and 13 in that discussion, unless there's anything. No, so that takes us on to the maternity incentive scheme, which is Sam.
Thank you, Chair. Again, relatively brief update, I hope. So the purpose of the paper is to update on compliance with the maternity incentive scheme. Following COVID, the deadline was extended to the end of July against compliance with the 10 safety actions. So the 2 areas of risk for compliance that we've discussed previously in board seminar with the service involve workforce and also training and education. So I'm just awaiting the action plan from the service around their plans to get up to trajectory for education, and they've assured me that they will be able to. And in terms of the business case required for the neonatal workforce, Jason and I are working with the teams to ensure that it's been to business planning a couple of times, it's gone back for further work. So Jason and I are working very closely with the service to ensure that we get that business case shaped. There's quite a few sort of prescriptive elements that need to be noted in the minutes that you'll see in the paper as well, Katie.
Thanks, Sam. If I can just check that I've understood a couple of the things correctly. The workforce problem is not the current problem, it's the sustainability forward look problem where we're very worried about compliance. Have I understood that right?
Well, it's in relation to the BAPM standard, so it's more along the lines that we discussed when neonates presented their board seminar. So some of it's legacy, some of it's around temporary staffing, some of it's to align to the standards. But Jason and I are working closely with them.
Thank you. And then there were also a number of things which were about absence of formal records as opposed to a substantive problem that were picked up, and I think we should note some assurance comes from the fact that it's better to have inadequate formal recording but still got the stuff in place. Ideally, as we will have, everything will be there, but we shouldn't miss that, I think, in our minutes. Jason.
I was just going to say, and it's probably important for the minutes, that for both neonates and maternity, we've identified sources of funds that will cover the needs identified by the services. For maternity, it's actually going to be a bid for our share of the national funding, and for neonates, it's probably going to be the MIS rebate. So Sam and I are working through some areas where there's some technical improvements needed in the actual sort of business case that we put together, but we've got funding covered in the draft financial plan for both sets of requirements identified in this item.
Thanks so much, Jason. That's reassuring. Claire.
Just a quick question, and it may be my lack of knowledge in this area, but when I looked at it, I understand we're trying to aim for July, or that's the requirement. But some of the red areas where we've got some issues, I didn't really understand if we don't meet the July deadline, when we were planning to be able to do that by. So I think the message back from the service, so it's in relation to the training. There is a plan to meet that standard, Claire. I'm just looking for any others. And the other two are in relation to the workforce. Was there anyone in particular? Because the rest is compliant. No, I mean, it's really a question just to make sure that we sort of understand how long these things are going to take us to put in place. But I think we've sort of addressed it really.
So I think we're clear that we are moving on each of those. We've heard that there's some dependence on funding sources, but we've also heard what those sources might be. I think we should take assurance from the number of areas that are already compliant, and we should note that the area that's quite tricky around the neonatal workforce is one that we'd already received a briefing as the board on. So we were aware of the challenges of that, and we've heard from the staff their ideas to deal with that. So I think with that, bearing in mind that some of those things from the paper need to be incorporated into our minutes for the formal record, and Sam will pick that up with Katie, I can move us on to the regular reporting items. The first of which is mine, which is the Integrated Assurance Committee. You have a report from the last meeting, and as everybody on this board is part of the IAC, I hope that will sound familiar. But you also have the annual review of the work of the Integrated Assurance Committee, and I'd perhaps make a couple of observations about that. Colleagues on the board will remember that we did a sort of interim stock take, that the IAC was a new committee aimed to bring together the strands, and its ability to that has to some extent been influenced by COVID changing the way in which we operate, and in particular, I don't think we've cracked the use of deep dives, but we've picked that up separately across the committees as a programme. We do, I think, have recorded in the paper that despite that, broadly, there is a belief that the new IAC approach has moved us forward on the agenda, but I still think there's more that we could look for, and so we would be aiming to refine that further in the coming year. We've agreed with the Council of Governors that should be part of my objectives for the year, and to give them some assurance that we're operating in the way that we hope to. So we're not asking for new terms of reference at this stage, and we are suggesting that we've met our terms of reference in place, but we are thinking this is something that needs to be kept under review. So the invitation to you is to note the report of activity, but confirm that we have done what we said we would do within the constraints of COVID, renew the terms of reference going forward without change at this stage, but particularly have the chance to comment on what we should take into our further improvements for the work of IAC in the coming year. So that's the report from IAC, and I'll throw that open for comments and questions, but particularly those in relation to things to bear in mind as we improve further the contribution that committee makes to our assurance. So over to you. You're not obliged to say anything, but anything you do say will be taken down and put in the minutes. So, Sarah.
It's just a quick comment, really, Chair. It's just I think having the one meeting together brings it's a holistic review or view of everything, rather than the split between the old quality committee and the finance performance committee. So it looks at everything in the whole, which I think is the right way forward. So you know, yes, there's always things that we can improve, but I think it's a good way forward. So I really support the approach.
Thanks. We should note that we've had the divisional directors in that discussion, which has been helpful to the NEDs to see. Bruno.
We talked earlier about the importance of linking up the different sort of planning around demand capacity, workforce, finance. This integrated assurance committee builds on that need to have better sort of triangulation of those planning work streams, but also then the follow-up on the delivery of the plans. And besides the AIC, I can also just inform the board that the monthly, quarterly divisional reviews are using the same principle of much more integration and triangulation, and the quality of the data packs is improving, the consistency across divisions is improving. And so what will come to IAC will also be a better view of not only the plans, but also what plans have been able to be actually delivered and implemented.
Thank you. That's helpful to hear. Paula.
I think one of the strengths, I agree with everything that's been said, but one of the other strengths has been the divisional representation at IAC. I guess I hope that they have welcomed it. No doubt someone can tell us, but I think we need to just think if there's anything more we can do on that front. Are we happy with it as it is? And actually, in some ways, that's more dependent on how useful they find it and whether it's working for them. But it certainly seems to me to really add to have their representation. I'd encourage even more contribution, really.
I mean, I think the informal feedback is that they do welcome it, in part because they welcome the contact with the non-execs, so they have a much better understanding about the questions that we're asking, and they don't need to be filtered through anybody, which is really helpful. Anne, and then I'm going to try not to prolong this just because it's my committee. I don't want to prolong the discussion. It's not because I'm trying to avoid the scrutiny, it's just because I fear that people are saying things because they think they should. So I want to get on to the rest of the agenda. Anne.
Okay, so you and I had a bit of a discussion about this yesterday, and I've been thinking about it since. I think one area that I think we should just think about, and I know we've talked about the deep dives as a separate thing, but they're more of a big topic that we're going to delve into from time to time. I think that the session where we sort of pick up individual questions rather than presenting, I think is a good idea. But I'm just wondering whether, you know, the executive team maybe could pick one topic each time that they want to do a little bit more on, rather than just leaving it us to pick up whatever we feel we want to pick up, which might be our personal hobby horses or like finance in my case. But I don't know whether it's just something to think about, whether there could be maybe one topic that the exec choose each time that they want to just do a little bit more on as part of the time.
Thanks, Anne. As you say, we were sort of mulling this over yesterday. I also think that we need to have been more work on how we use the IPR generally and how we use it differently at the board and we use it at IAC, because it's helpful to have the same set of data because it makes it easy to see the trend, but it does mean that we tend to discuss some topics multiple times and that doesn't give us time on some others. So I think there's definitely some improvement that we can make on those things. I'm going to take Sarah and then I'm going to make an attempt to move on the agenda. Sarah.
Sorry, and just also, it made me think. I think we do tend to. Sometimes the topics are quite generic, and it's that focus on perhaps some more key topics, so we have a bit more in depth look at one particular area, and it may be an area that's just under the radar, and not really going either way. And why isn't it really improving, or what's happening? So, and perhaps it's areas that we don't talk about a lot, or we may consciously not want to talk about it, or not subconsciously to talk about it, if you like. So I just think we just need to perhaps look at that in the round. So I think that's a good comment. Thank you.
Thanks, Sarah. I think those are all sound comments. I think in terms of the board business today, they don't require an amendment to the terms of reference. They enable us, as proposed, to renew the terms of reference, but they do mean that we want to keep thinking about making better use of the time. And the feedback, I think, is that we're going in the right direction, but there's quite a lot more we can do to be more helpful and more constructively challenging. So I appreciate that, and I think that takes us on to the TME report, which again includes the annual report, and that's Bruno.
Thanks, Jonathan. And I'll just pick one topic for a deep dive to build on the previous discussion, and that is the culture and leadership item. And we will have a deep dive on that this afternoon. But I think it's actually quite good that despite the pandemic, we were able to continue on the program that we had started before the pandemic with the culture and leadership diagnostic and the design phase. We're now at the stage where we're still somewhat designing, but also implementing. And so we had good discussions at TME on the importance of culture and leadership, and we'll have plenty of time this afternoon to look into that. For the rest, there may be some areas of interest to the board that people have questions on. We took a couple of, I think, important decisions for certain patient groups around, for example, gene therapy and the spinal muscular atrophy, which are expensive sort of services, but quite important and life-changing for those patients.
Thank you, Bruno. Are there any comments or questions for Bruno? Okay, thank you very much. I'm not surprised at that, in that we're regularly kept briefed on what's going through TME, and so it would be a bit surprising if anything came through that was completely unexpected. The next item is the consultants' appointments, and you'll see that we've been quite busy appointing consultants, and I'm very grateful to colleagues who've chaired the advisory appointments committees, and I'll be very grateful for other colleagues who continue to chair them, and we're doing our best to free some time from the general board schedule to make that easier for people to do. But this is just for receiving and noting at this stage, and I hope that we're happy to do that. That sounds good. I'm also grateful to you all for having confirmed that you remain fit and proper people to sit around the board table. It's very important that we keep that under review. You know, as colleagues know from our own experience and elsewhere, it is possible for those things to slip through. I wouldn't have expected anything to come up, and nothing has come up. So it's excellent that you remain all fit and proper. And we should just note that formally. And then we get to the declaration of interests, gifts and hospitality. Hospitality has been pretty challenging in the last year, so it's probably not as problematic as previous. Eileen, are you going to present the paper? And then I've got Anne's hand that's come up. Eileen?
Apologies, Chair. I wasn't. I'm happy to just move straight to questions. The paper has been presented many times and colleagues have kindly contributed.
Thank you. Anne?
Despite the fact that it has been seen many times, I still find that there's an error on my interests on page 7 of the paper, so I really apologise if I've missed it. But there's on page 7, the words "churches from church" needs to come out. It was actually explaining why the above change had been made, and that's been, so it's just a minor issue, but we do need to get it right.
Okay.
Thank you, Anne.
Thank you. And I think that gets us to the end. Oh, Paula.
Sorry, I have a similar one. I have to make the same apology. There's a couple of tiny drafting points on mine, but the declarations are fine. There's a couple of bits that need refining for the annual report purposes.
Okay.
But the declaration companies are fine.
Okay, thank you.
Thank you, Paula.
We will all see this again as part of the annual report. So if anybody looks at it and does realise that there are typographical errors or any errors, if we can know in the next day, they'll be ready for the annual report reading at the end of the week, and for coming to board in, I think it's a couple of weeks' time that we're formally. Ash.
So I just noticed that mine's not on there yet, so probably needs to be added before.
So it won't
Not for the annual report, but for
because it's still coming. But it will go on the register of interest. I think that is all in hand, Ash, as I understand it. But obviously the timetable for producing the papers meant that wasn't in place.
Yeah, no, that's fine. Just obviously from the purpose of today, I'm here and it's not on there. That's all.
Thank you. It will be. I think then that's the end of the formal business. Eileen, we had a fairly good go on the CQC inspection issues earlier on. Is there anything that you've just reflected on that you might want to check that we've thought about, given that that was late coming to people last night, so there may be something extra?
Thank you, Chair. Although the paper was late to contain the same information as the briefing from last week, and I think we've had as good a robust discussion as we can possibly have, given the fact that it's verbal feedback, albeit now provided as a summary letter. It remains draft and subject to factual accuracy. And once we get the report, as we said, we will circulate that. But no, I think we have fulfilled the new requirement given by CQC on Monday in the late letter.
Thank you. And we won't wait to brief board members if anything does emerge in the draft report. We'll get that on as soon as we have it. In which case, I think somewhat unusually, we are slightly ahead of schedule. I don't propose to start the confidential business until the planned time of 1 o'clock, so people can have a slightly longer lunch break to do their emails or whatever. So thank you very much, everybody, and I will see you at 1 o'clock. Thank you.
Thank you, Chair.